What I'm going to run through here is the screen of iQudos, clinical screen, and we're going to just talk a bit about the various questions, which are really the clinical interaction between you and the patient. We're running a demo database here, and other patients exist, obviously. So we'll just click on a patient, so we'll click on verify and get that up. And obviously you can see the pathways as we discussed in the previous talk. There's the various pathways that are chosen. This is obviously specified from the hospital. And if you're going to resume session, so here's the clinical page. We're going to just talk through what the questions are about and what they mean. So the first bit to discuss are the bowel problems. So these are tick boxes. Ask the patient if they have the problems, tick a box if they do. And really these are most important or only important really for the patients that have had radiotherapy. We're looking for radiotherapy bowel toxicity and the sorts of things which we'll ask them about are constipation or diarrhea. Those will just be reported back in the software, but if they have persistent constipation or diarrhea, it's probably worth them discussing it with their GPs if it's an issue for them. And rectal bleeding, which again is something they should report to their GP. They're just tick boxes and they can be ticked on and off. The reason for these symptoms is obviously after radiotherapy, the rectum is changed a bit. The prostate lies just in front of the rectum, and therefore when the prostate's irradiated, you can get some damage to the rectum. And if you look at the rectum in that situation, you'll see that people often have what are called telangiectasia, so abnormal blood vessels in the rectal mucosa. And those may bleed and obviously be seen within stools. But it is important because in a very small number of patients, these people can go on to get bowel cancers from the radiotherapy. It tends to be late, but it is possible. Clearly, the most common reason is going to be telangiectasia or something ordinary like piles, which these patients can of course have, but it's something which is worth asking about. The next question is about the urinary symptoms. So here's the question here is, are you concerned about problems with your waterworks? Yes or no? And if yes is answered, then you can bring up one of these, which is this International Prostate Symptom Score Sheet, which is a series of questions about your urinary symptoms over the last month. And these are all of the classical symptoms that men complain about. These forms are actually easily downloadable off of the internet or you can print them out if you're running a physical clinic and give them to the patient, and they can answer them and tell you what the number is. But it's just to go through them. Over the last month, how often have you had a sensation of emptying your bladder completely after urination? That means that they may have some resistance or poor emptying. Had to urinate again less than 2 hours after urinating. Stopped and started several times when urinating. So all of those are poor squeeze questions. The next one, found it difficult to postpone urination. That's about urgency. So some patients may have overactivity of the bladder, either just primarily, and in which case avoiding caffeinated drinks, etc. is a good idea, or maybe it's secondary to obstruction, and those will often complain of having a weak urinary stream, which is the next question just after, and again had to push or strain to begin urination. So first bit of questions there are about how well is your bladder empty. Next one here is about have you got any symptoms of overactivity, and then here what's the flow like. And then the last one is about getting up at night, which is the thing that most people moan about the most. The commonest urinary symptoms are going to be frequency and urgency. In that situation, the first thing to give the patient is simple lifestyle advice, which is being careful about the fluids they drink and the times they drink them, making sure that they avoid caffeinated drinks where possible. Make sure that you remind patients that there's usually as much caffeine in tea as there is in coffee, as well as soft drinks such as Coca-Cola, but patients don't often drink those. Also quite a lot of caffeine in chocolate, unfortunately, very sad. So those are the steps the patient should take to avoid those lifestyle factors that they can. If they're getting up at night a lot, sometimes fluid restriction helps. The other set of problems that patients might complain of are poor flow. Now those tend to be the sort of thing that actually might need further investigation, and the system will mention that a little in the letter. So if they say, well, my flow's awful, that's the sort of thing for them to pop back and discuss with their GP about. They just might be getting a stricture, a blockage within the urethra, or many of these men live a long while and they can develop benign prostate disease, which starts to cause blockage. So they certainly shouldn't be nervous that it represents prostate cancer, and it is nearly always easy to sort out. Next question is about erections. If you have problems with erections, are you concerned about them? Many men will have problems with erections after treatment for prostate cancer, but the majority won't be concerned. If you say yes, then the software will provide some advice. And the advice for these men is usually to see the GP to see whether they're suitable for tablets such as sildenafil. Over and above that, the next step is usually vacuum devices. So vacuum tumescence device is rather like a perspex tube, a plastic tube. Penis is put inside with a bit of jelly around the base of the penis. A vacuum is produced, and that produces an erection. Before the vacuum is let down, there's a latex ring which sits on the penile device, and that's pulled down onto the base of the penis. The patient lets down the vacuum, and then the device is taken off. And that will provide a serviceable erection for many men, most men. Obviously, there are downsides. It's quite mechanical, so a lot of men shy away from it for that reason. The other problem with it is that the end of the penis from the latex ring onward is erect, but the base isn't. So that may be of concern to some men, but it's certainly usable. And then the final step is often injections with prostaglandin analogues, and that will produce an erection that will last for 40 minutes or so once the dose is right. But those have to be organised usually in a specialist clinic. But the first two, the tablets and the vacuum tumescence devices, are available within the community for community prescription in most places. Next question is about weight loss. It's rare for men to lose a lot of weight in prostate cancer and have no symptoms, but again, it's worth recording. And then this question is an important one: bone pain, which is continuous and difficult to ignore. One of the places where prostate cancer can spread is into the bones. It tends to be the bones which contain marrow, so the ones which are most affected are the spinal column, and sometimes the femur or the pelvis, and the ribs are quite common sites of deposits. So a man who complains of bone pain, which feels like toothache, it's persistent, usually 24 hours a day, rather than the flitting aches and pains we all get, that may be bone pain. So that's where you would answer yes to that. And then the final question is one which isn't actually used in the system at the moment, but it's to give a guide of how fit the patient is, which is performance status. And there's a series of questions here. That's not usually going to change very often, so you don't necessarily have to ask that every 6 months, but it should be updated if the patient's general status changes. Once those are filled in and the pathology tab is filled in here for the PSA with a test date, and then you simply click on Analyze, and that will generate a letter for the patient.